Good day, students. So I'm going to introduce you to image interpretation of the brain. And the first one that we're going to start with is traumatic conditions of the brain. I'm also going to provide to you a spreadsheet where you need to identify some of the normal anatomy on different slices of a CT scan so that it's easier for you to understand the pathology on the CT scans. So at the end of the session, I hope you would be able to gain an appreciation for the importance of timely CT scanning, but also to be able to differentiate between different types of brain trauma following head injury. It's really important that you are able to distinguish between acute and chronic brain injuries, and then also to appreciate secondary effects of brain trauma as well as its radiographic appearances. So some of the resources, so I'm going to refer you again to Otto Chan's book, and it's chapter 8, which is on the head, and that focuses on CT scans of the brain. It includes the ABC search strategy for the brain, but also some of the important traumatic as well as stroke conditions. And then the Australian College for Emergency Medicine has got guidelines on diagnostic imaging, so please go to this link, have a look at it, and especially if you look at the CT head trauma advice that they give. They also have a flow chart for patients presenting with trauma of the head to the emergency department. So why do you need to do this? As you are aware, the MRPBA and its professional capabilities expects from graduates to be able to identify certain conditions. And one of those is an expectation that you will be able to identify significant emergency conditions on a CT scan. And these include acute brain hemorrhage, signs of subarachnoid hemorrhage versus a subdural, and then also skull fractures. I've given you the link there to the documents that we are talking about. Now, the NICE clinical guidelines is guidance that has been developed in the UK, but some of it has been adopted in Australia as well. This gives you a nice idea of when a patient should be referred for a CT scan. So if the patient is sent for a CT scan, if the Glasgow Coma scale is less than 13 on initial assessment, or if it's less than 15 2 hours after the injury, and then also if there is a suspected open or depressed skull fracture. So those are the main indications for a CT scan. And also if there's any signs of a basal skull fracture, and some of the signs would be hemotympanum, that means that there's bleeding through the middle ear, so you see blood leaking through the ear. Panda eyes, it's also known as raccoon eyes, and that's where the patient has got blue rings around the eye indicating some hemorrhage. And then if there's CSF leaking from the ear or the nose, and battle sign is where there's ecchymosis. So ecchymosis means the bluish tinge that we see after trauma, and that is at the behind the ear. If a patient has more than one episode of vomiting in adults or 3 or more episodes of vomiting in children, and if any patient has a seizure after head trauma, then also bleeding disorders. So if there's a history of bleeding or clotting disorders, or if the patient is currently on treatment with warfarin, and if there's some loss of consciousness or amnesia, patients that are receiving antiplatelet therapy may also be at increased risk of intracranial bleeding. And then a focal neurological deficit, that means that if there's either a paralysis or if the patient is unaware or unconscious. So getting to the ABCs when you assess a CT scan. So the A stands for air spaces, B is for bones, but also for the brain parenchyma. C is for the cerebrospinal fluid spaces, D is for the dural spaces, E is for the eyes, and F is for face, as well as foreign bodies. So with the airspace, it's just a reminder of the anatomy of the ventricles. So on a lateral view, you are able to see the horns of the lateral ventricles, and the choroid plexus sits within the lateral ventricles where the CSF is produced, and then it flows through the third ventricle and then the cerebral aqueduct into the fourth ventricle, and it will go down the spine and then circulate again. Apologies for that. And then this is a superior view where we have the lateral ventricles, and here you can see it has anterior horns and then temporal horns and posterior horns. And here we've got the third ventricle and the cerebral aqueduct and then the fourth ventricle. So on a CT scan, the air spaces that you should be able to identify would be the sinuses as well, depending on this level of the slice. So here we have the frontal sinuses and the ethmoid sinuses, as well as the mastoid air cells, and then abnormal air. So here you can see this abnormal air sitting outside of the brain, which is called a pneumocephalus. So with the bones, you need to play around with the windowing of the brain scan so that you can see the bones carefully. And what you want to look out for is signs of scalp or soft tissue swelling, any ideas of any evidence of a depressed fracture or any embedded bone fragments. And then if there's fractures or erosions, and look for changes in density in the bone like sclerotic or lucent bone lesions. So in this case, you can see that we have got some scalp swelling on the right side, the occipital part. But if you look at the occipital bone, you can see that there are erosions of the skull. And this can be associated with either primary or secondary tumors. And now next, the brain parenchyma. So looking for changes in density, so either low density or high density. The other important thing is to look for a mass effect. So just looking at this image here, we can see that our ventricles are nice and central. The pineal gland is also central. But at the image at the top, you can see that the ventricles has been pushed over to the one side. And that's what we mean when we talk about a mass effect. So low density brain lesions are normally non-hemorrhagic contusions or diffuse axonal shear injuries. So this is an example of a low density brain lesion. And then high density would be very dense, and that is normally an indication of acute bleeding, as we can see on the right side of the brain where there is a subdural hematoma. And then we can also see there's some intracerebral bleeding, so little punctate lesions of hematomas. So the cerebrospinal fluid spaces, so look that the ventricles are normal, that they are in their normal position. Also the basal cisterns as well as the sulci, all of those contain the CSF. So if there's any bleeding in the brain, it can actually leak into the ventricles. So what you want to look for is loss of symmetry, so that the ventricles on the opposite side does not look the same, and then also signs of hydrocephalus, which means that the ventricles are enlarged. So in this case here we have got a bleed, and that's our fourth ventricle, so you can see that there's blood there. But we can also see that the temporal horns of the ventricles are dilated, and we can see that the posterior horns of the ventricles are quite dilated, and that's a sign of hydrocephalus. So the dural spaces involves the subarachnoid space, which is the space between the arachnoid and the pia mater. The subdural space is the space between the dura and the arachnoid mater, and the extradural is the space between the dura and the inner table of the skull. So if we look at the case at the top, we can see that we have a subdural. There's bleeding between the dura and the arachnoid mater, and if we see it's quite low density, so this tells us that this is a chronic bleed. And then on the image at the bottom, we can see that we've got an extradural because the bleeding is between the dura and the inner table of the skull. Subarachnoid bleeding is recognized by high densities within the cerebral sulci, and here we can see this is where the sylvian fissures normally are, and we can see that there is blood within that sylvian fissure. Then moving on to the eyes and the face. So with the eyes, we want to see if there's any orbital fracture, so looking at the bony structures, and then also if there's any hematomas. A globe injury is when there's a penetration of the front of the eye with a foreign body, and that will then cause damage to the sclera or the cornea. Optic nerve damage, so the optic nerve normally runs here, so if there's anything like a tumor or any bleeding or hematoma that can cause that, and then also any foreign bodies within the eyes, which can be quite common, especially with welders. So here we have an image of the eye on a plain image, and you can see there's a number of fractures there. On a CT scan, a foreign body, and this is a patient with a foreign object that was actually accidentally pushed through the nose and it went through into the brain. Chopstick injury. So with head trauma, we can have primary and secondary effects. The primary effects are normally penetrating injury, so it's a missile type of injury like a gunshot wound to the head, and this can result in bleeding, a hematoma, and then you could have traumatic subarachnoid hemorrhage, contusion, intracerebral hematoma, intraventricular hemorrhage, or it can also be because of non-accidental trauma in the pediatric patient. Secondary effects of head trauma includes intracranial herniation, and that means where a part of the brain has shifted to another part of the brain. It can either move across to the opposite side, some of it. And then we could have traumatic cerebral edema. Normally, those patients are unconscious, and they could be unconscious for quite a long time, and it can actually result in brain death. So let's first look at missile and penetrating injury. So these are high velocity projectiles, and the prognosis can range from brain death to full recovery. So what would you see on imaging? There could be single or multiple intracranial fragments, especially if it's a bullet that has fragmented into little pieces. You look out for signs of pneumocephalus, and then also the entry and the exit wound. Normally the entry wound is smaller and the exit wound would be bigger. And then also the site of entry, quite often there might be bone fragments or embedded bullets. And then if there's hemorrhage, try and identify the type of bleed. So here we have a patient who was shot, and you can actually see how the bullet came in. Here you can see the entry wound, and then as it goes through, it becomes the exit wound is then bigger. You can also see on that image fragments as well. So an epidural hematoma is a collection of blood between the inner table of the skull and the dura mater. It's 90% arterial and 10% venous. Normally the patient has a classic lucid interval, and if the patient is scanned in time and the management occurs immediately, the patient will have a good outcome with prompt diagnosis and treatment. However, if it goes undiagnosed, because of the fact that it's an arterial bleed, the patient could collapse and die. Our imaging findings, a very hyperdense bleed, which is extraaxial in a non-enhanced CT scan, and that is in the acute phase. Normally you would see that there's compression of ventricles and also displacement of the underlying brain and subarachnoid spaces. So associated things to look for signs of skull fractures, any subdural bleeding or contusion. So here we have a coronal section which shows an epidural bleed, and then also a CT scan where you can see the epidural hematoma, and you can see there is midline shift. The ventricle should be in the middle, and it's not, it's been displaced. You can also notice that the anterior horns of the lateral ventricle is compressed on the side where there's bleed. So you can see that there's asymmetry of the ventricles, and also here we can see the asymmetry of the ventricles. So CT scan then, here is a hyperdense biconvex extraaxial mass with displacement. Again, you can see the massive displacement of the midline structures. So with evolution over time, you will find that where it's very dense, it becomes less dense over time. A subdural hematoma in the acute phase, which is normally up to 3 days, you will see a very dense hemorrhagic collection in the subdural space, and about 70% will have associated abnormalities. The prognosis is poor in acute subdural hematoma, can be up to 90% mortality, and especially if the midline shift is greater than 20 millimeter, it's correlated with a poor outcome. So imaging findings then, the bleeding is crescent shape, and in the acute phase, the bleeding will be homogeneous and very dense, and it lies within the extraaxial collection. And on the same side, the ipsilateral side, you will see that there's compression, but also displacement of the underlying brain. It's important to be aware that the density of the hematoma vary with age as the hemorrhage becomes reorganized. So here we have a collection, a subdural collection, and on the CT scan you can also see on this coronal image that there is a subdural collection. Once again, very hyperdense bleeding. So this is acute phase. Then you can see a bleeding that is less hyperdense, which means that it has changed over time. What's important again is the midline shift. You can see the ventricles has been shifted over to the left side, but also the ventricles has been severely compressed. In the subacute phase, which is normally greater than 3 days and up to 3 weeks, sometimes if it's the first scan that's been done and there's a high suspicion of brain trauma, if they don't see a hematoma, then the patient should receive contrast, especially because it can be isodense, meaning that it's difficult to distinguish the bleed from the normal brain. So imaging findings then, a crescent-shaped bleed, which is either isodense, which is similar to the brain tissue, or hypodense, so it is less dense than the normal brain tissue. Some of the things that you can pick up would be a gray-white matter displacement, especially medially. So in this case, on the right side, you can see that there is a bleed which could be easily missed, but you should not be able to miss that because you can see there's a midline shift. The ventricles has been pushed over to the left side. And then if we look at this image here, you can see it's become much more hypodense in comparison to the rest of the brain. And once again, there is movement of the midline structures. With chronic subdural hematoma, that is where the injury happened more than 3 weeks ago. Contrast enhancement might really be needed here to differentiate the chronic subdural from the normal brain tissue. It will have the similar crescent-shaped collection with enhancing surrounding membranes. Something else to remember, and especially in the older population where our older patients can fall quite regularly. If you have a bilateral bleed, you won't find that there is a midline shift, as is the case because of the fact that the bleeds are on both sides, and it actually keeps the midline structure central. Now, if this was isodense, meaning that it was the same density of the brain, this could be missing. That's why it's sometimes so important to give contrast, because the contrast won't cross the blood-brain barrier and it will make this stand out. And then on this image here, we have a large hypodense area, but you can see that the gray-white matter, especially on the medial side, has been displaced. And there's also compression of the posterior ventricles. You can only see the one on the right side. It's a different case. Subarachnoid hemorrhage has the same appearance in a patient with trauma as a patient who has had a stroke. And what you're looking for is blood within the subarachnoid spaces, and this sits between the pia and the arachnoid membranes. Signs of a patient with subarachnoid hemorrhage is headaches, loss of consciousness, and emesis, which means vomiting, with trauma being the cause. So the appearances look exactly the same if the patient had trauma or whether the patient had a stroke. So on a non-enhanced CT scan, there will be high density within the subarachnoid spaces and the cisterns, and it looks, as I already mentioned, identical to an aneurysmal subarachnoid hemorrhage. So if you look at these images, you'll be able to see here around the cisterns that there is an increase in density of blood uptake, and similar here as well within the subarachnoid spaces. So contusion, this is an injury that involves the surface of the brain. It's also known as Coup lesions, so that it impacts the side or ipsilateral side where the trauma has taken place, and it's associated with fractures of the skull. This can be quite subtle, and it's sometimes not visible in the first couple of hours, and therefore if CT scan is normal and there's a high suspicion, then an MRI should be done so that it can detect the presence and the extent of lesions. So as I said already, in the early hours it may be normal. After 24 to 48 hours, multiple new hypodense lesions might become visible, and then over time they will have a worsening mass effect with delayed hyperdense hemorrhages. In the chronic phase, these bleeds can change from isodense to hypodense, so once again then contrast media would be quite useful. And here we can see multiple bleeds varying in size, the image on the right side, and then here is just a collection of lots of little multiple bleeds. So intracerebral hematoma develops as a complication of contusion or torn vessels within the substance of the brain. So on a CT scan, you would see acute hemorrhage, very hyperdense within the brain substance, and then around that acute hemorrhage you could see surrounding edema. There could also be delayed hematomas at the site of the contusion. So here we've got an example of a large frontoparietal hematoma, and you can see there's again displacement of the midline structures as well as compression of the ventricular structures on that side. And then you can see here is the brain is less dense, and that is because of edema around that area. On the image on this side, we have a bleed within the left basal ganglia, and it's an intracerebral hematoma. It's important to note that we can see structures that looks quite dense, but these are normal findings. So here in the middle, we have the pineal gland, which is calcified, but we also have calcified choroid plexus, which is also quite normal. Bleed in the intracerebral area can also spill into the ventricles, and normally that indicates a very poor prognosis. So here we have severe bilateral bleeding within the ventricle spaces, and you can see the anterior as well as the posterior horns are affected. You can also see that the ventricles are dilated and that the brain parenchyma, the gray-white matter differentiation is very poor. Then our non-accidental injuries. So that's when there's brain trauma inflicted on a child, and it's the most common cause of death in infancy. Things to look for, apart from what we look for in the brain. So looking for healing fractures at different ages. And then with our limbs, look for metaphyseal corner fractures. In the chest for posterior rib fractures, scapular fractures or sternal fractures, and then also spine fractures. MRI is very useful to document the age of the bleed, and then CT of the abdomen if there are multiple injuries. But looking at the brain now, so with the brain there will be multiple injuries at different stages of evolution, and then look for signs of scalp injuries and then also skull fractures, as well as intracerebral hemorrhages and cerebral contusions. So here we have one example of an NAI, and you can see in this case that we have got a subdural hemorrhage. It's hypodense, which tells you that it is chronic. But on the right side, we also have a chronic bleed, but then we also have a new acute bleed. So it's acute on chronic bleed on the right temporal parietal, which is very typical of an NAI. Our secondary or vascular effects of trauma. So as you've seen, there can be a midline shift. We call that herniation of the brain from one compartment to the other. And here we have got what we call subfalcine herniation, where the falx cerebri shifts over to the opposite side. These patients normally present with increased intracranial pressure. So there's a bleed, and you can see that the midline, the subfalcine region has moved over to the other side, and that's what we call herniation. Traumatic edema of the brain. Imaging findings, normally the ventricles are compressed, and then you would find that there's effacement of the sulci, and also loss of gray matter, white matter interfaces. And then you can see signs of herniation of the brain. If you have signs of brain edema plus increased intracranial pressure, that prognosis is very poor. Quite often with severe cerebral edema, there might not be a bleed. However, this patient will be in an unconscious state for a while, and then in the end the brain just becomes irretrievable, and quite often they have to make the very difficult decision to actually switch off the equipment that keeps the patient alive. So here we have a patient with severe cerebral edema. You can see that we have lost the normal gray-white matter interfaces. You can't distinguish it. There's compression of the ventricles. We can barely see any ventricles. And then there's also obliteration of our subarachnoid spaces. And there's a little bit of bleeding within the cisterns. So brain death means there's irreversible cessation of the brain function. Normally, for brain death to be diagnosed, they need about 2 tests. So they would do an EEG and maybe a nuclear medicine scan to see if there's any brain activity. So if they do a CT scan, the imaging findings would show severe and diffuse cerebral edema, as well as effacement of the grey matter, white matter borders, as we've seen in the previous case. In a contrast enhanced scan, there'll be no enhancement of intracranial arteries or veins, but as I mentioned, the best clinical tool will be your EEG plus a brain scintigraphy. So EEG is electroencephalogram. So here's a case of irreversible brain damage. We have a massively left hemisphere infarction. There's diffuse cerebral swelling. So this patient is basically has no brain function. So in summary then, really important that when a patient is referred for a CT scan, that the patient is scanned as soon as possible. So the first available slot, patient needs to be scanned, and then that there should be a radiologist available to provide a report, as a timely management is pivotal to the outcome and the management of the patients. So radiographers therefore need to appreciate the appearances that they see on a CT scan, because quite often they do these scans after hours, in the early hours of the morning, and you don't always have a radiologist around you. So you need to ensure that there's someone that can provide a report immediately so that immediate intervention can take place. It's important to be able to differentiate between the different stages of brain bleeds, from acute to subacute to chronic, as this influences the clinical management of patients with head trauma. Thank you.